So my presentation is going to be on prompt ITI. And I think ITI poses a challenge for everyone in that, at our center we have 700 hemophilia patients, but at any time we're maybe only tolerizing 5. So when you're tolerizing such a small number, it doesn't give you a lot of ongoing experience. And if the number of patients at your center is much smaller, I would assume that's the case for you as well. Here are my disclosures. So I thought I would start today with a case. So this is a 10-month-old Burmese male, negative family history of hemophilia. Family had been in the States for a short period of time. Mom could speak English, but the rest of the family was not native speakers. He presented in the hospital with left knee pain and swelling and a prolonged PTT. During his evaluation, once he was transferred to us, we found his factor VIII level was less than 1, testing for, we wanted to test him for type 3 von Willebrand's, and that was normal, and his factor IX was normal as well. So he was hospitalized and treated for a knee bleed. While he was there, a central line was placed so we could begin prophylaxis once he went home. So he was discharged at 12 factor exposure days. He was then on every 3-day prophylaxis. So in outpatient follow-up 1 week later, what we found is he was really not having any bleeding issues. His central line was functioning very well. The family had been taught a total of 14 exposure days. But on return on his laboratory evaluation, his factor VIII was less than 1, and we found a 3 Bethesda unit inhibitor. So what's our next steps? And I think this is, first of all, it would be great if we had a crystal ball and we would know what his course would be like. But so what are some of the options? And I think all of us probably say, well, it depends. I want to know more about this patient. What type of mutation does he have? Is there a family history of hemophilia, possibly inhibitor? How's his venous access? Because if we want to do any type of therapy, we need good, consistent venous access. What are his bleeding risks? What's the family ability? So that's one option. So you might hold factor VIII and recheck inhibitor in 1 to 2 weeks. And the rationale, maybe avoiding future exposure to factor VIII. Maybe it's a transient inhibitor, maybe it's a high-responding inhibitor. Who knows, but let's just stop everything and have him come back. You may continue his prophylactic regimen. Remember, he's on every 3 days. He hasn't had bleeding. And recheck his inhibitor in 1 to 2 weeks. You already have venous access. The current treatment seems to be working. And maybe when he comes back, the inhibitor will no longer be a problem. Or you can begin immune tolerance and still have him come back in 1 to 2 weeks to recheck. We already have venous access. So what we would maybe do, what we would do at our center, begin at 100 units per kilo per day, regroup after the next blood draw. So what happened to him was we started daily infusions, and remember we had already placed the central line, so that was a bonus because we could easily infuse him. His inhibitor 10 days later came back at 5 Bethesda units. We continued on 100 units per kilo per day, but 1 month later, now he's at 13. So he's what you would consider a high-responding inhibitor. And looking back, his initial titer was low. We didn't know where he would go, but once we continued to expose him, he then became a high-responding inhibitor. So what do we really want for this patient? At the end of the day, we want to decrease his morbidity and mortality. And it's not just the number of the inhibitor. It's target joints, arthropathy, it's intracranial hemorrhage, it's other types of bleeding episodes, and he has a central line, and now we're worried about bacteremia as well. If we look at the international ITI study, which Chris talked about, and we really wanted to wait for his inhibitor to drop back to less than 10, we know that on the study it took an average of 5.5 months, and they considered to completely then tolerize really can take up to 21 months when the patient returns to a negative inhibitor titer and effective prophylaxis. But one thing the study did say was that the longer the inhibitor is present, the higher the risk of complications. So we look at age-related injuries because that's what I'm worried about for this patient. He's a toddler, he's got an inhibitor, and now he's in his home acting like a toddler. So we know now we're kind of beat the clock. Because what do toddlers do? They climb out of cribs, they climb up dressers, they climb on the sink, and just when you think you have them in the safe environment, they climb over the gate. So while we're having this wait, if we decided to have a waiting game, we know that the bleeding risk is very high for not only joint disease, but intracranial hemorrhage as well. There is bypassing agent prophylaxis, but we know that's not ideal either because recombinant 7A has a short half-life. And if I really wanted his factor VIII to truly come down, there is some amnestic response that they get using the APCCs. So this is a study that, that looked at 5, it was retrospective, similar to the problem with a lot of our studies, and it looked at 55 patients with severe factor VIII. It looked at race and ethnicity, it looked at inhibitor onset, start date, the starting inhibitor titer, and also what the peak titer was. And they found that the low responding inhibitors, the success rate was 100%, and high responding inhibitors, it was pretty high too. It was 88%. And then this study, what we did, and I'm saying we because I'll have a disclaimer, I'm part of this et al. We divided the high-risk group into 3 subgroups. Those who had ITI within 1 month of detection, those who started ITI within 1 to 6 months of detection, and those who started ITI greater than 6 months of detection. And what we found was that those who started within 1 month, there was a statistically significant difference in their abilities to respond to ITI, and it didn't matter what the peak titer was. So like I said, disclaimer, I'm part of this et al. Group. So what's the rationale of starting prompt ITI regardless of titer? Well, you might decrease the risk of time for high-risk bleeding episodes, which at the end of the day, that's where we want our patients, to emerge from immune tolerance and to emerge from being a toddler without bleeding into their head and also having healthy joints. There may be, if we can intervene in the pathway causing the immune response before it becomes entrenched, there might be a shift toward tolerance. And really a very short interval, what we found in our study, is critical to a high success rate, regardless of what their starting titer was. So back to our case. What did we do for this patient over the next year? Well, I think we've tried everything. We had extended half-life factor VIII at 100 to 200 units per kilo per day. When his inhibitor was above 13 or higher, we also added some sort of prophylaxis with that. We also tried factor VIII with von Willebrand protein as well. And then we started rituximab. And if you looked at the 4 doses that he got, prior to the first dose, he was 16. Prior to the second dose, that's when we had his peak titer of 44. The third dose, 18. And prior to the 4th dose, he was at 5 Bethesda units. And 2 weeks after the completion of the rituximab, his inhibitor was then undetectable. We were able to put him then on every other day prophylaxis at 100 units per kilo. So that's just the history of his treatment regimen. But let's talk about his bleeding during ITI. At 10 months of age, he had a left knee bleed, and that's what led to his diagnosis of hemophilia. At 11 months, he was on factor VIII daily, and he had another left knee bleed. At 15 months, when he was on a von Willebrand-containing product, he had a thigh hematoma related to his immunization, but at 18 months, he had a subdural hematoma, also a left knee bleed, and that's when we started the rituximab. By 19 months, he had another left knee bleed, and at that time, he was on factor VIII and recombinant 7A daily. And that's really when his first inhibitor titer was less than 10, or actually it should be less than 1. And by 20 months, he was tolerized. But during that 9-month period of time, he had suffered an intracranial hemorrhage, and we were seeing an emerging left knee target joint. So I wish we had the cookbook when we talk about immune tolerance. As you can see, we use multiple things throughout his course of immune tolerance. But we don't have the London cookbook. I'd like to have the immune tolerance cookbook. I haven't quite found it in the bookstore here, but and what we end up doing is ITI, which I tend to think of, I'll try it. Why not? See if it works, we'll try it. So when we think about immune tolerance and what kind of regimens we might use, I think we think of what dose, how often, What product do we use? What's the frequency of inhibitor levels? How do we adjust treatment, and when do we adjust treatment? Do we use immune modulation such as rituximab? And what's the success? So I think not the London Cookbook, but the UK has given us some nice protocols to really start to think about. And their protocol looked at cost effectiveness and really long-term musculoskeletal outcomes to have better outcomes by minimizing bleeding. They looked at patients, a good risk, which is a peak titer of less than 200, start of ITI, less than 10 Bethesda units, and the poor risk was everyone else. And then they revised the recommendations in 2017, and how they revised it was they said, instead of waiting for the inhibitor to drop below 10, go ahead and start immediately. So to start immediately, you have to know immediately. So part of it was surveillance. So looking at every 3 exposure days, checking the level to seeing if they had an inhibitor until they reached the first 20 exposure days. And if they found an inhibitor on greater than 2 occasions and it was interfering with routine prophylaxis, starting that aggressive tolerance. So this is just their cookbook, if anyone's interested, because I don't know, like in the US, it's just practice. It's what we've done before, it's what's worked for us in the past. I thought this was just a nice way to think about it, and I'm not saying this is the right way that we would do it, but it is a good guide. So, really looking at what your starting titer is to help you start therapy. But I think the important part of this regimen is really frequent monitoring of the patient and making adjustments based on what the patient's telling you and what their response is. So if I could make my recipe card, what would it look like? A cup of factor concentrate, give immediately, half a cup of bypassing agent if prophy is desired, a sprinkle of luck, bake at 98.6 degrees Fahrenheit or 37 degrees Celsius. Check frequently for a response. When complete, slowly remove from ITI and allow to cool under a prophy regimen. Thank you.